Sir, I'm just finding out it. Anyone? Please give me more answers or some suggestion. 42-year-old gentleman. So what are your differential diagnosis? Yeah. Differential diagnosis. So one could be a 42 years old gentleman, no comorbidities. So if he is a smoker, one differential diagnosis would be a peripheral artery occlusive disease, which is also called as thromboangiitis obliterans. Okay, that can be one differential diagnosis. Otherwise, in such scenario, though I am projecting a very rare scenario, you should always remember that it can be due to thromboembolic phenomenon, which can be due to his comorbidity, some other comorbidity which he is not aware of. For example, a connective tissue disorders leading to thromboembolic phenomenon. Or this one diagnosis is also a rare complexity, rare condition which can lead to this complication. Fine, let's go on to his examination. His pulse was irregularly irregular. That is one clue. Okay, so that suggests that there is only one diagnosis in the entire world for irregularly irregular pulse. That is your atrial fibrillation. Okay, so this gives one clue that probably this is thromboembolic. So all other vital parameters were normal, but distal leg pulses were absent. Okay, so what are the key things which we have identified from this? So one is peripheral artery occlusive disease plus importance. So these two we are, we have got a symptoms and signs with the evidence of an atrial fibrillation. And on examination, there is parasternal heave. Why do a normal individual have a parasternal heave? Parasternum, basically the parasternum, the area behind the sternum is your right ventricle. Exactly behind the sternum is your right ventricle. So when there is a right ventricle abnormality, it can cause heave. Okay. And there is a palpable P2. So palpable P2 with the parasternal heave, what does it suggest? Okay, fine. Then what else is there? There is a ejection systolic murmur. Ejection systolic murmur. Okay. And the apex, there were no murmurs. So this is a tricky scenario. Basically, I don't want to project the answer so obvious. Okay, we'll see, go on further. So if you look at the ECG, if you look at the QRS complexes, if you calculate the space between each and every QRS complexes, it is varying, yes or no? So this is the rhythm strip in any ECG. Okay, they will take this lead 2 for a prolonged duration in the lowermost part of the ECG. Okay, so if you carefully look at the gap between these two are different. Am I right? So that itself suggests that there is irregular rhythm and there is no constant PVS. Sometimes the PVS is hiding, sometimes it is not there at all. So that itself suggests that this is a atrial fibrillation with rapid ventricular response. Yeah. All right. Fine. Atrial fibrillation is seen in the ECG. Any other clue? Nothing much. No other clues. Let's go on. So the diagnosis will be a Leydig syndrome. Of course, it is not very obvious. See, Leydig syndrome can be due to two components. One is peripheral artery occlusive disease per se. A patient more than 60 years coming with peripheral artery occlusive disease, atherosclerosis at an etiology, can present with this syndromic complex like lower limb claudication, impotence, and absent distal pulses. That is also on Leydig syndrome. And one another differential diagnosis is patients with mitral stenosis having had long-term, thromboembolic manifestations. Thromboembolus, like it is dislodging. The thrombus is forming, getting dislodged. Like that, it is going, accumulating, and one point of time they manifest with this component, which is nothing but Leydig syndrome. The scenario which I wanted to introduce to you is a mitral stenosis can rarely lead to this manifestation as well. Okay, let's go on to the topic per se. So, what do you understand by the term mitral stenosis? Mitral stenosis is nothing but narrowing of the mitral valve. You know that there are 4 valves in the heart. There are 2 in the atrioventricular junction. One is your aortic and pulmonary valve. Whereas ventriculo-arterial, I am repeating again, 2 valves in the atrioventricular junction, which is your mitral and tricuspid valve. There are 2 valves in the ventriculo-arterial junction. They are aortic and pulmonary valves. Correct. So mitral valve has an important role because it enables the left ventricle to get filled and push the blood forward through the aorta to all our body. Correct. So looking at the anatomy, mitral valve is a bileaflet valve. Okay, only 2 leaflets. Rest all valves have tri-leaflet valve normally. There are abnormalities, and one important abnormality is a bicuspid aortic valve, which can lead to various manifestations that we can discuss in subsequent classes. And the normal area will be 4 to 6 centimeters square. So, what constitutes the complex? Your mitral valve apparatus complex. What constitutes it? So, there will be annulus, which is the fibroskeleton. Okay, if you see at the image, there will be annulus. Okay, and then there will be leaflets. 1, 2. There are 2 leaflets that I will show in the next slide. You can understand very well. Then there are chordae tendineae. So these are the chordae tendineae, caudal attachments, and then the papillary muscle. Okay, so papillary muscle, and then comes your myocardium. So this is the complex, your mitral valve apparatus complex. Okay, so there are few points which you should understand. See, if you look at in the, like, this is a cut section, you have removed all the atrium and looking from above. Okay, see, this is your mitral valve and this is your tricuspid valve. You're just looking from above. Okay, so if you carefully see this anterior mitral, this is anterior mitral leaflet. Anterior mitral leaflet is looking large, circular, correct? And this posterior mitral leaflet is semilunar in shape. Okay, that is one thing. And the posterior mitral leaflet is having only single supply from RCA, single blood supply. So when there is a infarction, myocardial infarction, then this leaflet can become abnormal and can lead to mitral regurgitation. This is one point you should be able to understand. All right. Then coming to the epidemiology. So this rheumatic heart disease, mitral stenosis, one of the part of rheumatic heart disease, is a, it's an evolving process. It has evolved because of a basic disease which has happened some 20 years ago. That is your rheumatic fever. Okay. Of course, all rheumatic fevers are not, they don't manifest with symptoms. Okay. But it is because of the rheumatic fever as an insult, this mitral stenosis occurs, usually after 2 decades. Really, all mitral stenosis need to be presenting in 30 to 40 years? Not like that. There is another entity called juvenile mitral stenosis, which can present in age group less than 20 years as well. Okay, and in developing countries, this is not perfectly correct, because we see many patients coming at 30 years of age group as well. Okay, but remember, the primary insult is nothing but your rheumatic fever. Rheumatic fever. So rheumatic fever, what is the most common age group when this rheumatic fever occurs? It is 5 to 15 years of age. Group A beta hemolytic streptococci can lead to rheumatic fever, which is nothing but an autoimmune kind of disease. Okay, basically the body tries to protect against this organism and finally end up producing antibodies which end up killing our own body. Okay, that is what is happening. These antibodies will go form against your own synovium, your heart, your brain. So that leads to manifestation of your rheumatic fever. Okay, and finally this rheumatic fever can be controlled very well at the onset only. So ideally rheumatic fever, if properly treated, will subside. Okay, but as the days progresses, the primary insult can lead to rheumatic heart disease, and mitral stenosis is the most common rheumatic heart disease by which the patient presents with. All right. So coming to the etiology, so as we discussed already, rheumatic fever is the most common cause, and other causes include congenital, and as congenital mitral stenosis, or this mitral annular calcification. Okay, now this is becoming the most common causes in developed countries, and other diseases are connective tissue disorders like SLE and rheumatoid arthritis, left atrial myxoma, which can mimic a mitral stenosis physiology. This myxoma will go and occlude the mitral orifice. Okay, so you see the heart, you have a tricuspid valve here, your mitral valve here, and this myxoma usually arises from the intraatrial septum and sits here and occludes the flow from above downwards. So that's how it mimics a mitral stenosis. And then infective endocarditis with the vegetation, that also can cause your mitral stenosis kind of physiology. So coming to the pathophysiology, only 40% of the patients present with pure mitral stenosis. So there will always be mitral stenosis with mitral regurgitation or mitral stenosis with aortic regurgitation. Like that, there are various presentations. Okay, it's a mix of presentations. Remember that only 40% will have isolated mitral stenosis. So how does it occur? So first, the valve gets inflamed. Okay, then it becomes thickened. Okay, then there will be calcification. Then your commissures fuses. So if you carefully see the mitral valve, it will be like this. Okay, so these are the leaflets. Imagine this is the anterior and posterior. This part, no, this is the junction of the two leaflets. This is called commissures. So the commissures will also fuses, and commissure will become calcified. Okay, and finally what happens is the valve cusps becomes rigid. Okay, and final presentation of your stenosis, and that leads to your typical fish mouth or buttonhole appearance. Okay, understood. So this is how the mitral stenosis evolves. So this is one thing. One is obstruction to the blood flow, and this creates a Virchow's triad. So stasis or hypercoagulable situation. So everything will happen with this mitral stenosis per se. And if the patient develops atrial fibrillation, this can lead to a substrate for clot formation. Okay, so atrial fibrillation patients, especially with mitral stenosis, there is stasis, there is irregular heart rate. So what happens? Finally, there will be clot formation, especially in the left atrial appendage. Okay, left atrial appendage. Coming to the hemodynamics. So what is the hallmark? If you ask me what is the hallmark, like to tell that there is mitral stenosis, the hallmark is, one second, I'll just take my pen. Yeah. So the hallmark is LV atrioventricular pressure gradient. What is the pressure gradient? Okay. If you see the normal heart, okay, this atrium and ventricle, this is the valve. This is your mitral valve. There will be difference in pressure between the atrium and ventricle. Okay, generally they see the valve nicely opens and the blood nicely fills from the atrium to the ventricle. There will not be any pressure gradient or difference in pressures between the atrium and ventricle, especially during the diastole. Okay, but these patients have diastolic pressure gradient, which is the hemodynamic hallmark of mitral stenosis. Okay, so when the mitral area is less than 2 centimeter square, only with elevated left atrial pressure the cardiac output can be maintained. Okay, got it? Any doubts so far? Any doubts? Any doubts, friends? Shall I go ahead? Fine. So, okay. So coming to the pathophysiology, what happened? The hemodynamic pathophysiology. So finally, LV is okay only. There is no problem with the LV per se. Only the problem is in mitral valve. So mitral valve is problematic. So that will lead to your increased pulmonary venous pressure, which is also called as pulmonary venous congestion. Okay. And this will lead to increase in pulmonary artery pressure, which is also called as pulmonary artery hypertension. Okay, and finally there will be decrease in pulmonary complaint. The pulmonary, there is a limit up to which the pulmonary vessel can expand and contract. So once that situation is reached, these patients will develop exertional dyspnea. Okay, and what happens to the LV diastolic pressure, the left ventricle diastolic pressure and ejection fraction? So ejection fraction is a simple concept. Okay, ejection fraction is nothing but the amount of blood which is being received into the ventricle, which is being ejected out of the left ventricle. Okay, normally the end diastolic volume will be 120 ml. At the end of diastole, 120 ml of blood will be there in the left ventricle. Okay, and out of which how much will be ejected? Stroke volume, which is called stroke volume, will be 70 ml. Okay, and how much will be remaining end systolic? End systolic, there will be 50 ml of blood remaining in the ventricle. Okay, this is the normal physiology. Okay, so ejection fraction usually in a normal individual will be more than 55 to 60%. Okay, normal this thing is ejection fraction is 55 to 60%. Ejection fraction is given by the formula stroke volume. One second. Yeah, stroke volume by end diastolic volume into 100. Okay, this is the normal ejection fraction. So nothing happens to the left ventricle per se. It is because of the mitral valve which is obstructing flow into the left ventricle, the patient is manifesting with symptoms. Can tricuspid regurgitation and pulmonary regurgitation occur because of MS? Yes, definitely yes. Okay. So what happens is in this patient's mitral stenosis is there. I told pulmonary venous congestion will happen. Pulmonary arterial hypertension will happen. So who feeds this pulmonary artery? It is the right ventricle, right? Right ventricle is pushing blood into the pulmonary artery, pulmonary vein, and then comes the LA, correct? So what happens is because of the pulmonary hypertension, the right ventricle becomes dilated. So this right ventricle will lead to pulmonary artery. So these patients, the right ventricle becomes dilated, okay, and right ventricle dilatation can lead to functional tricuspid regurgitation because that valve will, like the valve will be, connected to the right ventricle. So the right ventricle enlarges, so there will be central non-coapting zone which leads to your regurgitation, tricuspid regurgitation, okay. And pulmonary regurgitation can also occur because the pulmonary artery dilates, so thereby the pulmonary valve also will widen apart, and that can manifest with pulmonary regurgitation. These two also can occur. Pulmonary hypertension can occur in mitral stenosis, or its usual sequelae in mitral stenosis. Why does it occur? One is because of the backward transmission of your left atrial pressure. Next is pulmonary arteriolar constriction, okay. Interstitial edema, okay. There will be capillary leak, and finally, as long-standing your pulmonary venous congestion, everything can cause pulmonary vascular resistance to increase, and that will manifest as pulmonary hypertension. So what are the symptoms by which these mitral stenosis patients present with? Mild mitral stenosis, there will not be any symptoms at all, except for certain conditions. So when the patient is becoming pregnant, the cardiac output and the volume will increase, and that can manifest with symptoms. Otherwise, if the patient is developing tachycardia because of fever or atrial fibrillation, so in these conditions, the patient will present with symptoms, okay. So mitral stenosis, if it is mild, will not present with symptoms at all, will not need any intervention, just have to wait and watch, okay. They will become symptomatic only in these conditions. If they are very much exerting, very hard work they are doing, then they may have dyspnea. If they have atrial fibrillation, they can have dyspnea. If they have anemia or pregnancy, then they may become dyspneic, okay. So if there is atrial fibrillation, there will be accelerated progression of symptoms, and hemoptysis can occur because of your pulmonary venous rupture, okay. That can happen as a complication of your pulmonary hypertension, okay. And recurrent pulmonary infections can occur. Finally, fibrosis can occur and impair the oxygenation, okay. Fine. So finally, systemic embolization that we saw soon scenarios, lyric syndrome we saw, and then stroke. Your CVA can also occur because of this mitral stenosis. So what are the signs? How they are present? The mitral stenosis patient present, especially we saw. Okay, correct. So what are the symptoms we saw? And now it is time to pick the diagnosis. The final idea of physician is pick up the signs and make a proper diagnosis and make a proper management. So when you hear these symptoms, so in clinic, my professor used to tell me, if you have a patient who is coming with dyspnea and exertion, a young lady, 20 to 30 years of age, coming with dyspnea and exertion, and if the patient is lean, okay, it's underweight, then there are only two probable diagnoses. One is atrial septal defect, or another is mitral stenosis, okay. So like that, as soon as you look at the patient, you can make out that there is probable mitral stenosis. So one such thing is your mitral phases. It's not very common, not very obvious. It's difficult to see in different parts of the world. Basically complexion, unless they are white complexion, then it's difficult. Fair complexion is difficult, correct? So that is one thing. And second thing is JVP. There will be prominent A waves, especially if pulmonary hypertension is there. So JVP is a separate topic per se, okay, and A wave is produced by atrial contraction, just remember that, okay. And pulmonary hypertension or tricuspid stenosis is there, then they can have prominent A wave. And right ventricular heave, we saw in the first case scenario also, that if there is RV enlargement and that RV hypertrophy, then it can cause right ventricular heave. If you keep your heel of your hand and close to the chest and feel to be going up and down, okay, that is your RV heave, that can happen. And the important sign, which is pathognomic, or that one important sign is tapping apex beat, okay. So normally what is causing the apex beat is your left ventricle, okay. Left ventricle apex will cause the apex beat. But in mitral stenosis, the left ventricle is underfilled. Correct? So this underfill, your underfilled LV can lead to tapping apex beat. Okay. And S1 will be loud. Okay. So how to tell that S1 is loud? So if S1 is equal to aortic sound, that is aortic component, or your S2. See, S2 consists of two sounds. One is your aortic component, aortic sound, and pulmonary sound. Okay. When the S1 is equal to or more than S2 in the base of the heart, not at the apex. Okay. Normally, the louder sound will be S2. So if the S1 is equal to A2, or if it is more louder than aortic valve, your aortic component, aortic closure sound, then it is called loud S1. Okay, that is one manifestation. Then you can hear opening snap. So opening snap is because of your sudden opening of your pliable mitral leaflets. Mid diastolic murmur, it is a low pitched rumbling murmur. Okay, because there is a gradient difference of pressures between the atrium and the ventricle, there will be a mid diastolic murmur. Okay, so coming to the murmurs, when do you expect murmur? What is your idea behind murmur? We'll discuss murmurs a little bit and then we'll go further. Murmurs, when does it occur? One is, so idea is behind this turbulence. Normal blood in a stenosed valve or increased blood in normal valve. So you should remember these two things. Okay, when there is stenosis, okay, when there is valvular stenosis, the normal blood will find it difficult to traverse through. Okay, it's just imagine that if you are gardening, okay, you are taking a water tube and gardening or pressing the tube, there will be turbulence created. Similarly, in heart, if there is valvular stenosis, that can lead to turbulence, and that is manifested or heard as your murmur. Okay, or in patients with pregnancy, okay, or in patients with thyrotoxicosis, there will be increased amount of cardiac output. Okay, and that will traverse through the normal blood vessels, and that can cause a murmur. Okay, so these are the various things why murmur can occur. All right, fine. Coming to the slide. So next is your presystolic accentuation. I will explain why it happens. Okay. So we discussed about S1 in mitral stenosis. S1 will be usually loud, I told. Okay, fine. Can S1 be variable in mitral stenosis? Variable into like varying sound? Yes, definitely S1 can be variable. The reason is for atrial fibrillation. Okay, atrial fibrillation in mitral stenosis can lead to variable S1. Okay. So coming to the heart sounds. So we were discussing about the murmur, mid diastolic murmur, pre-systolic accentuation. So normally how they present is loud S1 will be there. Okay, then S2 will be heard. So this is S1, S2. Then you will have the opening snap. Again S1, S2. Okay, S1 is loud, so I am putting a big line. Then comes S2. Okay, so loud S1, then comes the opening snap. Opening snap occurs here. Then there will be a diastolic murmur. Murmur will be had, and then that increases in intensity, which is also called as presystolic accentuation. Okay, remember that the duration between S1 and S2 is your systole, and S2 and S1 is your diastole. Okay, so in mitral stenosis, in a classical case of mitral stenosis, there will be loud S1 and opening snap and mid diastolic murmur and a presystolic accentuation. Okay, fine. So what are the signs apart from these? One is your loud P2 can happen with pulmonary hypertension. Okay, and hepatomegaly, everything. If the patient goes to RV failure, finally, like if there is severe tight mitral stenosis, finally pressures are getting transmitted to the right ventricle, if he's going for RV failure kind of future, then ankle edema, ascites, pleural effusion, everything can occur. Okay, tell me what is Carvalho's sign? Carvalho's sign. Carvalho's sign is nothing but your increase in blood flow. So TR murmur. I told that functional tricuspid regurgitation can occur in mitral stenosis. The same thing, when it increases in intensity with inspiration, it is called as Carvallo sign, which can happen in mitral stenosis. Okay. So what is silent MS? Silent MS means in very tight valve, you might not be able to hear the mid-diastolic murmur of mitral stenosis. So that is called silent mitral stenosis. And Graham-Steele murmur is nothing but pulmonary hypertension. I told already, PR can occur, correct? Pulmonary regurgitation can occur because pulmonary artery hypertension will make the pulmonary artery dilated, okay, and that will lead to regurgitation through the pulmonary valve. That is your pulmonary regurgitation, and the pulmonary regurgitation murmur is called as Graham-Steele murmur. Okay, it is a diastolic murmur. Okay. So coming to the ECG, what are the ECG manifestations of mitral stenosis? One is P mitral, another is P pulmonale, another is right axis deviation and right ventricular hypertrophy, and atrial fibrillation. Atrial fibrillation can occur as the disease progresses, okay, as the valve becomes more and more tight. So what is P mitral? P mitral is nothing but your broad P wave. So if you see a normal ECG, you'll have a P wave, QRS complex, and then T wave. Okay, this is normal ECG. This is how it progresses. And P wave denotes atrial depolarization, QRS denotes ventricular depolarization, T wave denotes ventricular repolarization. Okay, if the P becomes very broad, so each, and there will be, if you see the ECG, there will be so five small boxes, one like large box, a lot of large boxes and small boxes. So each, if it is more than 2.5 small boxes, the P wave breadth, if the P wave is very broad, rather than like this, very broad, then it is your P mitral. The P wave is very tall, then it is your P pulmonale. Okay, this indicates RV hypertrophy, and this P mitral indicates left atrial enlargement. Okay, so our right atrial enlargement will be depicted by your P pulmonale, and right axis deviation and right ventricular hypertrophy also can occur. Okay, these and all we can see separately in ECG classes. We'll go further. So if you carefully see this ECG, okay, I'll show you. So this P wave is not looking that. We should look specifically in lead 2. Okay, let's look at the lead 2. This is lead 2. Okay, if you carefully see, I'll zoom and show you. Okay, P wave is looking a little tall, correct? So if you see clearly, it is exceeding in three small boxes, correct? So that is suggestive of your P pulmonale. And if you see the V1, lead V1, okay, that I will show you. Normally, the lead V1 there will be biphasic T wave. Okay, so first, okay, see, this is the P wave in lead V1 normally biphasic. Okay, the first part depicts the right atrial depolarization, second part depicts the left atrial depolarization. If it is very much deep, then it suggests a left atrial enlargement. Okay, so it is also there. So this is a case of mitral stenosis. Okay, fine. So what does this ECG show? This ECG shows a atrial fibrillation. If you can see, very easy, it's a very easy diagnosis. See this, you just compare the intervals. Okay, see here, you compare the intervals, correct? So the difference is there. So irregularly irregular. Okay, narrow complex. It is ECG QRS is narrow complex, less than 120 millisecond. If it is there, then it is nothing but your atrial fibrillation. And this peculiar pattern, this is sawtoothing, okay, which occurs in atrial flutter. All right. So these patients are even susceptible to atrial flutter as well. Patients can present with atrial fibrillation, or there can be atrial flutter. Okay, there can be mix of atrial fibrillation and flutter as well. Okay, fine. So what is the role of echocardiography? So current era, more than clinical investigations have come up. Okay, clinically if you are missing also, investigation wise you can able to pick up. Okay, echocardiography plays vital role in the diagnosis and management of mitral stenosis. Okay, so what all we can understand? So how is the chamber size? How is the flow? Everything we can understand. How is the severity? We can understand. Calcification is there or not? We can understand, and whether it is suitable for balloon mitral valvotomy also we can understand. Okay, finally the valve is becoming very stenosed. Okay, very tight. Then we should do some treatment. Okay, we'll come to the treatment part later. And the echocardiography plays a vital role in understanding how severe is the valve, how tight is the valve, whether it is amenable for balloon mitral valvotomy or not, whether the patient will have any complication or not, how to do the procedure. Everything will be given by your echocardiography. Okay. So there is some special echo called transesophageal echo. Transesophageal echo. Is it mandatory? It is recommended to do transesophageal echo because left atrial appendage. I told about this point earlier. In patients with mitral stenosis, if the patient is having atrial fibrillation, they are susceptible to clot formation, and this clot forms especially in the left atrial appendage because their blood will lie stagnantly. Okay. So if there is LAA clot, then BMV, if you do a balloon mitral valvotomy, that will lead to thromboembolic manifestation and can lead to stroke. So it is recommended that you go ahead with the transesophageal echo. It's like an endoscopy only, okay, and see the valve, how it is, whether it is amenable or not, it is very much calcified or not. Okay, you can assess it again and look at the left atrial appendage, look for any clots. If there is no clots, then go ahead, you can do a balloon mitral valvotomy. All right. So I'm projecting some echo images as well for your understanding. Okay, if any doubts, you can ask me. See, this is your normal echo. This is your mitral stenosis echo. So what is happening if you carefully observe? So this part, the mitral valve is nicely opening, correct? This is the mitral valve. So basically how we are doing is, usually this view is called as parasternal long axis view. In this, what happens is we can see the heart like this. Okay. Your LA, LV, your aorta will go from here, and this will be your RV. Interventricular septum will be laying here. Okay, this is your parasternal long axis view. Okay, so this is your left. One second. Yeah, left atrium is here, left ventricle is here. Okay, and here lies the mitral valve. Understood? So, yeah. So if you carefully see here, the valve is not able to open properly, and there is left atrial enlargement. Correct? So echo can easily pick up a diagnosis of mitral stenosis. Okay, and see above you can see the aortic valve. Okay, yeah. And see in this image, there's a peculiar appearance. In the previous images, that image is called, that appearance is called as, see, there will be bowing of this anterior mitral leaflet. Okay, I'll show you again. Yeah. So if this appearance, if you see the leaflet here, okay, this appearance is called as hockey stick sign. It's like a hockey stick. Okay, this happens in mitral stenosis. Okay, and this appearance, if you see the color image here, this is a Doppler. You're just putting a color Doppler and seeing how the velocities are. This is called as candlestick appearance. This image is nothing but your inverted normal anatomical view. Okay, this is called as apical four-chamber view, where you keep the echo transducer at the apex and look at the heart. Okay, so the transducer lies from here. The transducer is here, and you are looking from the left ventricle, right ventricle, LV, right ventricle, LA is here, and right atrium is there. Okay, so this appearance is called candlestick appearance, which happens classically in mitral stenosis. Okay, and if you carefully see in this image, this is nothing but your parasternal short axis view. So if you have a LV like this, and your mitral valve like this, LA like this. Okay, this parasternal short axis will cut across the left ventricle and looks at it. Okay, so if you carefully see, this is the mitral valve. Okay, and the mitral valve is opening very slightly. Okay, and this is looking like a buttonhole or fish mouth appearance. Correct? So fish mouth or buttonhole appearance. Okay, understood? Fine. So what are the X-ray signs which you can make radiologically? X-ray, this is the classical thing, the straightening of left heart border. Okay, and another you can see that there are two shadow here, shadow and shadow appearance. Okay, basically this part usually in a normal X-ray there will be aortic knuckle and the pulmonary bay followed by your left ventricle. Okay, whereas this pulmonary artery gets dilated here and this obliterates this area. Okay, and in the right side, if you see, there are two shadows, shadow and shadow appearance. One is a left atrial shadow, another is a right atrial shadow. Okay, so these occurs classically in mitral stenosis. One is a straightening of left border, dilatation of pulmonary artery, and this can be seen by a lateral view only with barium swallow that we are not drawing routinely, and curly B lines when there is interlobular septal edema. Okay, that can manifest with curly B lines. there are three curly lines. Remember that curly B lines occur here. So this is curly B lines. If you see, you can see, if you carefully see, there is white, correct? So there are white lines, correct, from the periphery. These are called as curly B lines. Orange lines are called as curly A lines, which occur from the middle. Okay, so I'll show you here. So whenever there is a line like this, that is curly A lines. And curly C lines are your reticulonodular opacities. These are curly C lines. Okay. All right. Fine. So how do you grade severity of mitral stenosis? Clinically, to tell that if a patient is having severe mitral stenosis, you should auscultate and look for aortic sound and the opening snap. Okay. So A2OS gap. So the narrower it is, severe it is. Okay, narrower is severe. Understood? Whereas the duration of the diastolic murmur, the longer it is, the severe it is. The longer the duration of diastolic murmur, the severe it is. Okay. Whereas the narrower the A2OS gap is, the severe it is. And echo-wise, when there is mitral valve area of less than 1.5 centimeter square, and if the gradient between the left atrium and left ventricle is more than 10 millimeter of mercury, then it is suggestive of severe mitral stenosis. Okay. Coming to the differential diagnosis, what are the differential diagnoses for a mitral stenosis? Mitral regurgitation. How come mitral regurgitation becoming differential diagnosis? Okay. In severe mitral regurgitation, what happens is the valve will leak, correct? Valve is leaking, that is called regurgitation, correct? So blood goes from LV to LA, and this increased amount of blood going into the left atrium will again come back to the left ventricle. That will produce turbulence here at the mitral area. Okay, so that will produce a mid-diastolic murmur. That is that also can produce your mid-diastolic murmur. So hence it is becoming differential diagnosis for mitral regurgitation. Whereas severe AR, aortic regurgitation, what happens is, I showed in the parasternal long axis view, echo I showed you, right? So I'll explain this in a separate page. So in the parasternal long axis view in the echo, we saw that aorta is lying here and your mitral valve is lying here. So when there is regurgitation from the aortic severe AR is there. Severe AR is there means this jet will prevent the opening of the mitral valve, anterior mitral valve leaflet. Okay, regurgitation of jet from the aorta will prevent the opening of mitral valve. Okay, thereby producing a mid-diastolic murmur. Okay, this is how this aortic regurgitation can be a differential diagnosis for mid-diastolic murmur. Okay, even tricuspid stenosis can produce mid-diastolic murmur. ASD, because of the increased flow through the RA and RV, can produce mid-diastolic murmur, and atrial myxoma can produce a mid-diastolic murmur. So this atrial myxoma is nothing but a tumor, okay, benign tumor from the intra-atrial septum protruding into the mitral valve orifice. The classical sound which can be heard because of this atrial myxoma is your atrial myxoma tumor plop. Okay, so tumor plop. It's a classical sound which can be heard in atrial myxoma. Coming to the management, how are you going to manage a patient with mitral stenosis? Number one, prevent recurrent rheumatic fever. See, ideally rheumatic fever is the one which has led to the problem, mitral stenosis, correct? If it again and again happens, the valve will damaged very faster and can lead to worsening dangerous complications, okay, warranting mitral valve replacement. And then symptom-free life, that is also one of the targets. And then prevent the complications or treat the complications of mitral stenosis and monitor the disease progression often. If it is becoming severe, of course, it's an indication for mitral valve replacement or a bundle mitral valvotomy. And there are two interventions available. That is, one is your percutaneous and another is surgical. Okay. So medical management, penicillin prophylaxis. Okay, that is very, very, very important. At least till 40 years of age, you have to give penicillin prophylaxis. Beta blocker. Why beta blocker? So when there is mitral stenosis, the blood flow into the left ventricle is getting affected. Correct? So how do you enhance the blood flow into the left ventricle? As you reduce the heart rate, okay, normal heart rate is 60 to 100. If you reduce the heart rate, keep it less than 72 or 70, then the diastolic time will increase. So the heart fills during the diastole, you know that. So the left ventricle fills during the diastole, correct? So you can increase that diastolic period by giving a beta blocker, and that can help you in symptom relief, okay? And diuretics, especially with the pulmonary venous congestion, the diuretics will help. Sodium intake, the more you take sodium, the more water will get retained in the body. So sodium restriction will help you. Finally, if the patient is having atrial fibrillation, then you can use digoxin, beta blocker, or dihydropyridine, calcium channel blocker. Okay, these are the various ways by which you can control the rate in atrial fibrillation and can prevent symptoms. And in any patient with atrial fibrillation, please remember to give warfarin, anticoagulant, mandatory. The reason being it predisposes the individual to get a stroke, thromboembolic manifestation. And the INR target in your atrial fibrillation is 2 to 3. Okay, it's very, very important. Even if the patient is not having atrial fibrillation, if the patient has severe mitral stenosis and a thromboembolic manifestation in the past, for example, if a patient is coming to you, 30-year-old lady who had got a CVA 2 years ago, and you are checking the echo telling that the patient has got mitral stenosis, then this patient also will benefit from anticoagulation. Even without atrial fibrillation, if the patient has severe MS with thromboembolic manifestation, you should recommend anticoagulation. Understood? Fine. So if there is recent onset atrial fibrillation, you can try cardioversion also, but remember to give at least 3 weeks of anticoagulation and rule out a left atrial thrombus by using a transesophageal echo. So what is this procedure? It is nothing but your balloon mitral valvotomy. Okay, using special balloons. Okay, there are two commonly used balloons. One is Acura, another is Jomiva. We use special balloons to go into the heart through the catheter, transfemoral will go through the right ventricle, right atrium will puncture into the septum and go into the left atrium and go into the left ventricle through the wire, and we can balloon dilate the mitral valve, and this has good results. Okay, so the same thing is explained here. See, through the IVC we are going. So IVC, RA, LA, and finally you are going into the LV and you're dilating the valve. Okay, fine. So when do you go for this procedure? So remember that all interventions, okay, whether it's surgical or medical, are indicated only in symptomatic severe patients. Okay, symptomatic severe mitral stenosis. Even surgical replacement is needed for patients who are symptomatic and severe mitral regurgitation. So these are the basic idea. Like for any valvular heart disease, when do we recommend to replace the valve? The answer should be symptomatic severe patients. Very simple. Okay, and valvotomy, previously we used to do surgical valvotomy. That means they will open the heart and they will go poke the mitral valve and make it dilate. Okay, now it is not preferred. Now the present modality is percutaneous mitral balloon valvotomy. We commonly call as balloon mitral, or BMV we call balloon mitral valvotomy. Okay, so ideal patients are one who doesn't have commissural calcium. Okay, calcium if it is more means there are possibility that the result will be suboptimal. Okay. And pregnancy, when a patient comes in pregnancy with severe mitral stenosis, this procedure is the treatment of choice. Okay, especially we do this procedure during the second trimester of pregnancy. And when do you go for mitral valve replacement? So the bad thing about mitral balloon valvotomy is there are chances that up to 5% patients can go for a mitral valve replacement because of MR, mitral regurgitation. Once you open the valve wide open, suddenly the patient will have severe MR and they can collapse on the table also, which can warrant an emergency surgical management. Okay, that is the danger about a balloon mitral valvotomy, but we are like, it's happening. Balloon mitral valvotomy, very good procedure. Okay, you're transcutaneously going and doing the valve dilatation. But there are certain scenarios where you cannot do a balloon mitral valvotomy. One is patient with moderate or severe MR. Okay, as long as the mitral regurgitation is mild, you can go ahead, no problem. Severe mitral stenosis with mild mitral regurgitation, you can go ahead for a balloon mitral valvotomy. Whereas if the patient has moderate or severe mitral regurgitation, severe leaking of the valve, then the only option will be your mitral valve replacement. Okay, and in the mitral valve, if previously there is already BMV is done, the valve is calcified, then in that case also you can go for your mitral valve replacement. If the valvotomy is unsuccessful, you can go for mitral valve replacement. Okay. So usually what they will do is just the caudal attachments and all they will preserve and just change the valve so that the ventricle dimensions will not get altered. Okay, fine. So we have come to the end of mitral stenosis. Is there any doubts? Any doubts?
One doubt was an X-ray.
Yeah.
Can you show that curly B and curly A? Can you just show me some?
Yeah, definitely.
Hello, doctor. There are a number of questions in the chat box.
Okay.
Kindly see them. Okay, thank you.
Sure, definitely. Yeah. This is the X-ray which shows curly A, B, and C lines. Is it okay?
Yes, sir. Yes, sir. One more doubt is there, sir.
Yeah,
sir,
yeah, please.
do we beta blocker?
Yeah.
Is it advisable to use metoprolol, or can we do cardioselective? That's like cardiologist can we use?
Yeah, generally in all the cardiac trials, there are these things which have come, 3 beta blockers are recommended. Okay, that is the mnemonic is MBC. Okay, so metoprolol, bisoprolol, or carvedilol. You can give any of them.
Okay. I think a specialty we are using bisoprolol, but when you go to government sector, we are using metoprolol
Yeah,
because
correct.
then from cardiology, when we are in cardiology, we are using properly carvedilol, sir.
Yeah, correct. Yeah, we can use it. Any of them is okay.
Yes.
Anything else? Any other doubts, please? Am I like my
Sir,
voice is okay, la? Or you want more louder? Is it okay?
Sir, some people have messaged that they can't hear, sir. In the
Yeah,
chat
but
box.
are you able to hear?
Yes, sir. I am able to hear properly, sir.
Yeah, okay, all right. So I think maybe some network issues.
sir,
So there
I
were
have
doubts
one.
actually. Yeah. Please go ahead.
Sir, why we usually see mitral stenosis in female patients? We comparatively male patients are very less.
Correct. I don't have a specific answer to this question. We see more females. That's the prevalence. Yeah.
Maybe, sir.
And there is yeah.
Maybe, sir, female have usually pregnancy-induced hypervolemic condition, so they become more symptomatic as compared to males.
Yeah, correct. They become more symptomatic and they can present earlier also. That is also one of the reasons why they present early, especially during pregnancy. They will have a volume overload condition and they will manifest.
My question is that why we can't give apixaban novel anticoagulants in MS patients?
Trials, it's basically trials. There are trials happening just comparing NOAC and your novel anticoagulant and this thing, your warfarin or acetylene. But they have the warfarin and acetylene have shown benefits. Okay, NOAC is not equivalent, especially in patients with mitral stenosis. There are trials which have proved that mitral regurgitation you can give NOAC, but not with mitral stenosis.
Sir, should we give anticoagulant to severe mitral stenosis without any AFib and LA thrombus?
Definitely, if the patient already had a thromboembolic manifestation. If the patient had a previous stroke, then yes, definitely you should give. Any other doubts?
Hello. Thank you for
Yeah.
the morning. Thank you for the presentation. Concerning the ECG findings, you
Yeah.
the P mitrally and the P pulmonale as being above ECG findings being above 2.5 boxes or 2.5 millimeter. Well, I don't know. I don't know for the P pulmonale to be above 2.5 and P mitrally to be above 3 boxes. I don't know. If it's contrary
for
to
EC remembering, I have mentioned 2.5, 2.5. Okay.
Yes.
There are differences.
So I felt it one should be 2.5. That's the P pulmonale. The mitrally should be 3.
Yeah. Fine. I think there are no other queries in the group. There is in the messages chat section. I can see that there are people who cannot hear it properly. Sorry about that. I think my audio is okay and network is also okay. I think. Can you see me? Like my video is okay, or is there any issue with the video also?
No, doctor. Everything is good. The thing is, there was one slide.
Okay.
In which you had made calcification, then commissure or whatever. I couldn't understand one of these. You had connected them with three.
I understand. Okay,
Yeah.
okay. No, the thing is, idea is very simple. The valve will start calcifying once the disease reaches a chronic stage. For example, to start with the mitral stenosis, the valves will be pliable, means they'll be easily opening and closing. Okay. Once after, for example, after 40 years of age or so, okay, after the disease progresses, the valve will lose its pliability. The valve will start calcifying, and the commissures, the joining area between the anterior and posterior mitral leaflet will also get calcified. Okay, thereby it loses the expansibility. Okay, so in such cases, when you are doing balloon mitral valvotomy, the valve might break. Okay, or it can lead to suboptimal results. Okay, only if the valve is pliable, you can hear a opening snap. Okay, once it is calcified, this opening snap also disappears, and the result which you are able to attain with the balloon mitral valvotomy will also be lost. Is it okay?
Yes, doctor. Thank you.
Thank you. There are too many messages.
When we are going to check calcification for deciding either we have to do MVR or other balloon valvuloplasty, then which modality is better for calcification? TEE or CT angio? Yes, CT calcium.
Transesophageal echo is more than enough.
Even for calcification?
Yeah. See, there is a score called your Wilkins score. Okay. So Wilkins score has many things. Okay. One among them is calcium. Okay. So we can very well visualize with the echo only. It will be very bright, echogenic, very echogenic. Okay. And with that, we can understand that the valve will not be favorable for a balloon mitral valvotomy.
Oh, thank you.
So, rheumatic fever, the guidelines say that penicillin is best. Once in 21 days, penicillin is best. Injection penicillin is best. Okay. Second option is your phenoxymethyl penicillin. Okay. Amoxicillin clavulanate is not recommended for prophylaxis. Shall we go further? Yes?
Yeah, yes, please. Okay.
Yeah, sure. So before going into the topic, see, I thought I will cover this mitral stenosis. I thought we'll finish a little early. Okay, so I wanted you all to take a break. Let's go ahead, take a break. Just spot the differences fast, and then we'll proceed further. Just for a change of mind, and so that we can come refreshed back. You can message that also if you are interested. Yeah, spot the differences. Yeah, correct. Ball position is one correct answer. Yeah. Flower pot, yeah, correct. Leaf in the flower pot is correct. Hindling is missing, correct. Scarf, very good. Red bow of dog, yeah, red bow, net collar, yeah, scarf. Ear, okay. Question of the ball, yeah, already told, as someone told. Fine, shall we go ahead? Are you all ready to listen to the next lecture? Yes? Okay, good. Yeah, correct. Final answer also came. Congrats to all of you. The curtain color, if you see carefully, the curtain color is, I'll show you. So this color, okay, this thing. Okay, finally this hind leg missing. Okay, these are the 5 differences. Okay, shall we go ahead? Yeah. So this is another case. So I've just given one MRCP scenario. Okay, so 28-year-old lady is presented with the emergency with breathing difficulty for almost 1 year, atypical chest pain for 6 months, fever on and off for the past 1 month, worsening leg swelling for the past 1 week. Not a diabetic or hypertensive, no rheumatic fever in the past. So we list out it first: dyspnea on exertion. Second, atypical chest pain. And third is your leg swelling. And fourth is your fever. These are the symptoms. So finally, as soon as you hear a scenario like this, young lady coming with dyspnea on exertion for prolonged duration and has got a fever which is not lasting as the usual course of a viral illness, then you should always suspect. Scenario is also, I will go suspect a infective endocarditis. Okay, fine. So looking at the vitals, pulse rate is 100, regular, BP is okay, and systolic murmur is there. So probably there is some valve issues, bilateral basic rupture are there. There is cardiac failure also. Okay, fine. Coming to the next, ECG. ECG, sinus rhythm. Okay, nothing much. If we carefully see, nothing much. Then looking at the X-ray, cardiac okay only. There is not much to suggest any problem. Yeah. Looking at the echo. So if you carefully see, I have projected some echo images before only, correct? So what is happening here? I'll play it again. Yeah. Yeah, carefully watch. This is the parasternal long axis view which I told you earlier, where you can see a left atrium, left ventricle, aorta, and this is your right ventricle. Okay. If you carefully look at this part, there is something floating from the leaflet, is it? Yes or no? So that suggests that this patient has got a vegetation and has got an infective endocarditis. Okay. And the basic pathophysiology was a mitral regurgitation. All right. So again, a fast recall. So I told that the 5 components in mitral valve apparatus, one is your leaflet, another is annulus, your chordae tendineae, okay, and papillary muscle and subjacent myocardium. These are the components of your mitral valve. And any problem with any of these can lead to mitral regurgitation. Is it okay? Yes? All right, fine. So going to the next slide. Yeah. So these are the pathophysiology slide. How all this mitral regurgitation can occur in what all conditions? Okay, I'm just zooming it. Yeah. Okay. If you carefully see, it is classified into 3 types, 4 types totally. Type 1, Type 2, Type 3, A and B. Okay. So Type 1 is normal leaflet motion. Type 2 is increased leaflet motion, and Type 3 is your restricted leaflet motion. Okay, normal leaflet motion, increased leaflet motion, and then finally it's a restricted leaflet motion. Okay, normal leaflet motion. So what could be the causes? One is your dilated cardiomyopathy, infective endocarditis, congenital. Okay, these are the various causes. Fine. Increased leaflet motion, what are they? They are your trauma, Ehlers-Danlos, your collagen vascular diseases. Okay, these and all can cause your increased leaflet motion. Okay, and then restricted leaflet motion can be due to radiation, carcinoid, or lupus, systemic lupus, connective tissue disorders. Okay, there will be overlap between these two. Okay, but remember that the basic pathophysiology is involving between your normal motion or increased motion or restricted motion. And restricted motion, whether it is restricted opening or restricted closing. Okay, these are the various pathology or pathophysiology behind your mitral regurgitation. Okay, fine. So coming to classification based on acute or chronic, okay, whether it is acute or chronic. So acute mitral regurgitation can occur as a component of the scenario which we saw, infective endocarditis, can be due to papillary muscle rupture post myocardial infarction, or it can be due to caudal rupture, your chordae tendineae can rupture. And mitral valve prolapse syndrome is one of the entity which can cause mitral regurgitation, and blunt trauma. Okay, these are the various causes wherein we get an acute cause of mitral regurgitation. So chronic cause of mitral regurgitation can be divided into primary and secondary. Okay, so primary and secondary. This is primary, secondary. So primary is something which affects the chordae and leaflets. Okay, So myxomatous, rheumatic fever or rheumatic heart disease, infective endocarditis, congenital and radiation. These are the things which can affect the valves per se, affecting the leaflets or cardiac per se. Whereas there are conditions without involving these people, these things, that leaflets and cardiac, they can lead to regurgitation. Okay. One is your dilated cardiomyopathy. One is a hypertrophic cardiomyopathy. Canonic atrial fibrillation can lead to dilatation of the annulus and can lead to regurgitation. And then ischemia, especially ischemia, chronic ischemia and dilated cardiomyopathy can also lead to this manifestation. Okay. So coming to the hemodynamics, what happens in mitral regurgitation? Normally what happens when the left ventricle contracts, the blood should go through the aorta into the peripheries, correct? Peripheral parts of the body. The blood should not backflow into the left atrium. Whereas in this mitral regurgitation, there is decrease in resistance to LV emptying because there is already one orifice above. See, this is one just cutting across. Okay, this is the tricuspid RV. So this aorta is draining here. There is a mitral valve lying here. Okay, normally the blood should go here only, whereas here it goes through both the ways. So there is decrease in the resistance to the LV emptying. There is decrease in afterload. So LV part of the LV is getting decompressed into the left atrium as well. And this leads to vigorous left ventricle contraction, relaxation, trying to push as much as possible towards the aorta and to the peripheries for end organ perfusion. Okay. And finally, what happens? The volume will increase over time. Over a period of time, the heart starts dilating. And finally, what happens? The heart cannot contract properly at all. And then that will lead to drop in cardiac output. Okay. This is how the pathophysiology of mitral regurgitation is. Okay. So what happens? We just see what happens normally. So I told already the end diastolic volume normally is 120 ml, end systolic volume is 50 ml, and the stroke volume is 70 ml. Your left atrial pressure. So behind the left, this is left ventricle, this is your aorta, and this is your left atrium. Okay. So left atrial pressure will be normally around 4 to 12. Okay, left atrial pressure 4 to 12 millimeter of mercury. Okay. Whereas in acute MR, what happens is acutely the blood starts regurgitating into the left atrium. So the left atrial pressure will go up. Okay, generally these patients will present as pulmonary edema. Okay. And another thing is the LV is briskly contracting to maintain the cardiac output, correct? So the end diastolic volume is same only, whereas end systolic volume is too low because the LV is getting decompressed into the left atrium and the aorta. So it is trying to maintain the cardiac output also. So the end systolic volume will be coming down. Okay, vigorous ventricular contraction will happen. Okay, whereas in chronic compensated MR, what happens is end diastolic volume will go up. There is constant regurgitation again going up. So blood is going up, again going down, going up, going down. This will lead to your ventricular chamber enlargement. Okay, and the stroke volume will be maintained somehow. Properly, it will be maintained. The ventricle will contract properly, aggressively, and maintain the cardiac outputs. Okay. Remember that acute severe MR is one of the surgical emergencies. Okay, you cannot maintain, the patient's heart cannot maintain cardiac output for a long duration. For example, 1 or 2 days maximum, within that we'll go for a failure, heart failure, and he will go for shock and he might die also, unless you surgically intervene. Okay, there are bridging therapy. For example, IABP, intra-aortic balloon counterpulsation, can help you in bridging the patient for a surgical therapy, but there is no curative therapy without surgery for a patient with acute severe mitral regurgitation. Whereas in a patient with chronic compensated MR, the LV is adapted. The LV has become big, is accommodating the increased blood and giving adequate cardiac outputs. Okay, that happens in a patient with chronic compensated MR. Whereas if this patient is prolonging, the LV is going on dilating, and at one point of time, there is a limit to everything. So this at one point of time, this chamber will lose its pumping capacity and it starts failing. So the cardiac output will start dropping. And finally, see, end diastolic volume is increasing, end systolic volume is also increasing, the cardiac output is not maintained. So this is one final stage. That is that in that stage, the patient will present with heart failure symptoms. Okay, fine. There is a notion in your medicine, which is also called as MR begets MR, because see, as the blood is going down and up again and again, so it's going into the LV, again going into the left atrium, like that it is going again and again. Finally, the LV starts dilating, and this dilatation itself will cause more MR. So that is MR begets MR. As soon as MR starts appearing, okay, the MR will gradually increase, and one point of time the LV will dilate. That itself also produce a MR, and this is a vicious cycle. Okay. So what are the symptoms of mitral regurgitation? See, the cardinal symptoms of cardiology, very few, only 5 symptoms. Okay. So one is your dyspnea, chest pain, second is chest pain, then third is your palpitation, fourth is syncope, and finally fifth is your pedal edema. These are the 5 cardinal symptoms. Okay, generally in any cardiac illness, these can occur. Okay. As regards to your valvular illness, okay, if a patient is having low cardiac output, then they will present with fatigue. Okay, part of the blood is regurgitating into the left atrium, the cardiac output is decreasing, so that this patient will present with fatigue. Okay, and when he is exerting, the cardiac output is not sufficient, so present with exertional dyspnea. Okay, and when the heart starts failing, this patient will present with orthopnea. Okay. In mitral stenosis, systemic embolization is much more common, but here it is less common. Okay, finally, everything is going to dilate the atrium, and the patient can go for a thromboembolic manifestation, can go for atrial fibrillation, which can predispose to thromboembolic manifestation. Okay, so atrial fibrillation will affect the course adversely, and palpitation can occur. Palpitation can be paroxysmal or persistent. Okay, so palpitation paroxysmally occurring is a sign of atrial fibrillation. Okay, so always ask the history of paroxysmal atrial fibrillation. So what are the signs with which this mitral regurgitation patients can present with? One is your hyperdynamic apex speed. Hyperdynamic apex speed. What is hyperdynamic apex speed? Okay, usually if you take your pulp of your finger and keep in your apex, okay, left fifth intercostal space, normal apex speed is half an inch close to the medial to the midclavicular line. Okay, it will be confined to one intercostal space. Okay, whereas in hyperdynamic apex speed, it will be confined to 2 intercostal spaces. Okay, that is one. And S1 is soft because the valve is not closing properly. See, S1 is produced by the atrioventricular closing, valve closing. So this valve is not closing properly, so that will lead to S1 being soft. And wide splitting of S2. Why wide splitting of S2? So normally, what is the sequence of heart sounds? If you carefully see, I'll draw and show you. Normally, S2 is the loudest sound, which has A2 and P2 components. Okay, S1, A2, P2. This is a normal heart sound. Okay, this is how the normal heart sounds progresses. So if a patient is having severe mitral regurgitation, what happens? Part of the blood will go into the left atrium, part of the blood will go into the aorta. Hence, the aortic valve closes earlier than usual. So normally, normal patient, this happens means in this mitral regurgitation patient, the aortic valve closes early, then comes the P2 at the normal area. So there will be wide physiological splitting of your second heart sound. So that is one of the important things to note. Okay, fine. So that suggests that severe MR is there. So this is one of the telltale sign of severe mitral regurgitation. Okay, and there will be rapid filling of left ventricle. So that can lead to your S3. Okay, so S3 occurs due to rapid filling of left ventricle, and that occurs following your S2. And S4 doesn't occur in severe mitral regurgitation unless it is acute. This is a very, very important point. S4 never occurs in severe mitral regurgitation unless it is acute. So acute severe MR, S4 is a sign. All right. And what else happens? There will be a pansystolic murmur which is heard in the apex and which radiates towards your axilla. Okay, you can very well hear it. Then acute severe MR. So I just wanted to tell briefly about acute severe MR before proceeding further, because my discussion will be based on a chronic severe MR which can occur in rheumatic heart disease, because even now the rheumatic heart disease is one of the most important reason why this mitral regurgitation occurs. And another reason behind it is your mitral valve prolapse, okay, which is a collagen problem. Okay, basically the valve loses its thing to close, okay, tendency to close. Fine. So in acute severe MR, I told one sign, S4 will occur, and there will not be any pansystolic murmur. There will be an early systolic murmur. Okay, so normally in severe MR, S1, S2 consists of A2 and P2, then goes S1. So this is the systolic phase. The pansystolic murmur will start here from S1 till the S2. Okay, this is how a normal pansystolic murmur will be in chronic severe MR. Okay, whereas here in acute severe MR, what happens is there will be an early systolic murmur. It will go like this. Okay, early systolic murmur, because rapid equalization of pressures will occur in the acute severe MR. All right. So how do you manage an acute severe MR? I told already it is a surgical management is primary. Okay, and that only helps the patient to survive long term. But in acute setting, what you can do is you can decrease the afterload. Okay, that by using a sodium nitroprusside. Okay. So, all right. Yeah. Number one is your sodium nitroprusside. And second thing will be used IABP as a bridge to your valve replacements. Okay, Dopamine also can help to some extent. Okay, it causes peripheral vasodilatation. At the same time, it increases in contractility. Basically, it acts as an inodilator kind of. So it will increase the cardiac output. It also decreases the afterload. That might helps in mitral regurgitation patients. All right. So secondary MR, as I discussed already, there is nothing to do with the valve leaflet per se, nothing to do with the chordae per se. Basically, the LV is getting dilated because of some other problem, and that is leading to non-coaptation of leaflets. Okay, the valve will not approximating each other, and there is leak from below upwards, left ventricle to the left atrium. All right. So severe MR, when do you say clinically? So clinically you can make out MR. Okay, so I told already the severe MR is going to manifest with the pansystolic movement, correct? So this pansystolic movement in medicine has only 4 differential diagnoses. Three are the more common, and one is little rarer, and which is coming up because of lot of procedures. Okay, so the first thing will be your mitral regurgitation. Second thing is your tricuspid regurgitation. Third thing is your BST. These are the 3 scenarios where you get a pansystolic movement. And another differential which is coming up is your prosthetic valve leak, paravalvular leak. Okay, if a patient is already gone a mitral valve replacement, there is leakage from adjacent to the sides of your valve suture area, then that is called as paravalvular leak. That can produce a pansystolic movement. All right. So these are the 3 differential diagnoses. Like these are 3 different common differential diagnoses when you have in a patient with your pansystolic movement. Okay. So if there is systolic thrill over the apex, then you should suspect a severe MR. If there is a large LV, means the LV is dilated down and out. Generally, the LV enlargement will lead to going the apex to down and out, whereas RV enlargement will push the laterally. Okay. And third is the presence of S3. So when there is rapid filling of large amount of blood from the left atrium to the left ventricle, that will produce a left S3. And finally, flow mid-diastolic movement. This I told already, correct? So in the differential diagnosis of mitral stenosis, MDM, I told certain differentials, right? Can we recall? So it's basically one is your tricuspid stenosis, another is your severe mitral regurgitation, where you have functional, large amount of blood going up and which is going down again. So through a normal valve, that can lead to a MDM, flow mitral mid-diastolic movement. Then we discussed about atrial septal defect. Then we discovered about our aortic regurgitation, which can impinge on the anterior mitral leaflet, thereby allowing it to open properly. So that can also produce a MDM. So here, this flow MDM is important in mitral regurgitation because that suggests that the patient has got a severe mitral regurgitation. All right. So looking at the echo, so same. If you carefully see, this leaflet is going down and there is a central area of non-coaptation. If you carefully see, okay. So that is like, there are 2 things. One is a flail and another is a prolapse. Okay, the valve prolapsing into the left atrium, that is one thing. And flail is the tip will easily float here and there and it will go into the left atrium. Okay, these are the various entities which can cause mitral regurgitation. Okay, so if you carefully see in these images, the same parasternal long axis view, we have put a color also. Color is showing that some jet is coming back, correct? See, this blue color jet is coming back from the left ventricle to the left atrium. That is nothing but your mitral regurgitation. All right. And this is the patient's echo with severe mitral regurgitation. Okay, where your 4-chamber view, this is a 4-chamber view. You have kept your probe here. You are seeing a probe from here to here and watching. Okay, see this jet. This is your LV, this is the LA. See, jet is, lot of jet is coming.
Away, sir, red means going away, sir.
Sorry?
The red color means it's going away, sir.
Basically, red is towards and blue is away.
Okay.
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 But there will be turbulence that will make us a little confused in a real time if you see. But generally, red is, see, something dangerous occurring means there is a red danger. Red is danger. Like that, remember like that. Okay. When it is going away, it is blue. Understood? Yeah. So how do we differentiate between aortic stenosis and mitral regurgitation? Why do we come across aortic stenosis as a differential in this patient? See, aortic stenosis also produces systolic murmur, harsh systolic. If you auscultate here, you can see a good aortic stenosis will produce murmur across the pericardium. Whereas good mitral regurgitation also can cause a murmur across the pericardium. So how will you differentiate between both? So just palpate the carotid. If the carotid is brisk, then it suggests that it is probably mitral regurgitation. Whereas if the carotid is slowly a slow upstroke, that pulsus parvus et tarda, slow upsloping pulse. So that suggests means this patient does have a aortic stenosis. Okay, looking at the carotids in a patient with a harsh systolic murmur, looking at the carotids will give you a clue whether this patient has an aortic stenosis or mitral regurgitation. Okay, Other differential diagnosis will be your mitral regurgitation and the tricuspid regurgitation. So what is the difference? So mitral regurgitation is best heard in your apex, okay, and will be radiated to the axilla. Okay, whereas this tricuspid regurgitation murmur will be best heard in the left lower sternal border, and this will be connected to your basically this increases in inspiration of the that is one thing, and there's no conduction clear cut. Okay, it will be heard best this area, parasternal area. That's all, nothing much. There is no specific conduction area. Aortic stenosis will conduct to carotids, agreed. Mitral regurgitation will conduct to axilla, agreed. But tricuspid regurgitation, there is no specific conduction area. Okay, it will be heard best here only. And there is respiratory variation between this mitral regurgitation and the tricuspid regurgitation. This mitral regurgitation increases with expiration, and tricuspid regurgitation will increase with inspiration. Okay, and in JVP, elevated JVP will be there in TR, and prominent V waves will be there. So basically, the V waves are coincident with your ventricular contraction. All right. So I think any doubts so far? Any doubts? Shall we go ahead? Yes.
Sir, regarding one
Yeah.
with hockey stick, can you just show, sir? Hockey stick.
Hockey stick. Hockey stick, huh?
Yes, sir.
Hockey stick you want to see. Okay, all right. Hockey stick. Basically, this echo has both mitral stenosis and regurgitation. I didn't project to you. So if you carefully watch the anterior mitral leaflet, this is the anterior mitral leaflet. Is it? Yes or no? So that is the anterior mitral leaflet.
Yes,
if you
yes,
see,
sir.
instead of opening like this valve will be bending like this. It will be bending like this. It's like a hockey stick. Okay. You can see, no, it is not opening properly.
Yeah, yes, sir.
Yeah, so that is the hockey stick sign. Actual thing I have put in the earlier slides, I'll show you at the end. Okay.
Yes, sir.
Fine. So, fine. So when do you go for a mitral valve replacement? Mitral valve replacement, we will go when the patient is symptomatic severe mitral regurgitation. If a patient is having symptomatic severe mitral regurgitation, go for mitral valve replacement. There are two modalities of treatment: mitral valve repair and replacement. Generally, younger age group with isolated mitral regurgitation, they prefer to do repair. But if it is mitral stenosis with regurgitation, if it is calcified, if it is not some like anatomy is not good, then they will replace the valve. Okay. So the first thing I told is symptomatic severe mitral regurgitation. Second thing will be even if the patient is asymptomatic, okay, and ejection fraction is 30 to 60%. See, this is very, very, very important. Okay, in normal patients, I told ejection fraction of more than 55 to 60% is fine, well and good. Whereas in mitral regurgitation, even if the ejection fraction is dropping to less than 60%, it suggests that the patient is going for decompensation. Okay, if within period of like few months to years time, he will go for LV dilatation and gross heart failure. Okay, sometimes with gross heart failure, it might not be able to bring back the LV function to normal also. So it is when, if you see that the echo's LV function is going from less than 60%, then please think about doing a mitral valve replacement. And if the LV and systolic diameter, so I showed you the parasternal long axis view, we measure basically in the parasternal long axis view. So septum is there, aorta is going from here, mitral valve is here. We measure this area. Okay. So at the end of diastole, end diastolic diameter and end systolic diameter. So LV is contracting and relaxing, contracting, relaxing. Okay. So this diameter, LV end systolic diameter is this thing, more than 4 centimeter. If it is dilating, so the LV end systolic diameter is gradually increasing. Okay. Then please think about going for a mitral valve replacement. Okay. Suppose even if the patient is having ejection fraction of more than 60%, but rapidly you're following up every 6 months and the patient is rapidly worsening, the EF is dropping from 65 to 60 and is going to drop down further. Okay. Even if the LV end systolic dimension is less than 4 centimeter, if there is rapid worsening of heart failure, rapid worsening of ejection fraction, and the end systolic dimension is going from 3.5 to 3.8, it is gradually going up, then please think about doing a mitral valve replacement. All right. So this is the basic guidelines regarding mitral valve replacement. And I want to project this. What is this? Any idea?
MITRA clip.
Excellent. MITRA clip. So what does the guidelines say about MITRA clip? So if a patient is having secondary mitral regurgitation, okay, and he is already on guideline directed medical therapy, GDMT is guideline directed medical therapy. Okay, severe stage T. Actually, we cardiologists classify stage 1 to A, B, C, D. A is at risk of MR, B is already mild or moderate, C is severe MR but without symptoms, D is symptomatic. Okay, severe MR, symptomatic. So if the LV ejection fraction is more than 50%, go for, if persistent symptoms, go for surgery. Okay, but if the LV function is not favorable, like less than 50%, and there is favorable anatomy, there are echo parameters which are there to tell you that whether you can go for end-stage mitral valve repair or not. Okay, in that case, you can go for a mitral valve end-stage repair. But if it is not a favorable anatomy, think about doing a surgery. Okay. But if the patient is going for CABG already, then no problem. You can go for open heart surgery only. Okay, open heart mitral valve replacement. Whereas if the patient is having your ejection fraction, low ejection fraction, and he is not going for a surgery, then you can think about going for a mitral clip. Okay. So this is what I wanted to highlight about mitral regurgitation. Okay, I don't want to take much because some symptoms will are common for both mitral stenosis and mitral regurgitation. Some symptoms present early in mitral stenosis. I told the thromboembolic manifestation will present early, whereas it occurs late here. Even the manifestation per se, if the rheumatic fever occurs at 5 to 15 years of age, the manifestation of mitral stenosis will occur by 30 to 40 years of age, whereas mitral regurgitation will manifest with 50 years, like at least 1 or 2 decades later, these patients will present with. Okay, so that's the difference. And mitral regurgitation and mitral replacement or repair, that surgeons will take the call based on the anatomy. They will decide what is the age, what is underlying risk factor. They will decide on that. Okay. So generally, what we do is, if we are we are sending a patient for CABG, like coronary artery bypass graft surgery. If you are taking a patient for coronary artery bypass graft surgery more than 40 years of age males or postmenopausal females, we generally do an angiogram and then we'll send them. The reason being, if they want a valve replacement also, valve replacement patient who might require a valve replacement open heart surgery, we will do an angiogram and delineate coronaries. If they want a CABG also, we will send them for CABG plus valve replacement. Okay, that's what the routine practice is. Got it? Shall I repeat it once again? So if we have a patient who is fit for a valve replacement surgery, we'll generally do angiogram before sending them, because they might require a coronary artery bypass graft surgery also, which we will put at a late. See, finally, you will replace the valve today, and after 10 years, the patient will come with ischemic heart disease and an angina. Then again, he'll have to go for a surgery, correct? So to prevent that, all patients who are sending for open heart surgery, okay, we'll do an angiogram before and then send them. So before going to recall, next slide is on recall. I want to recall before ending. So any doubts, please tell me.
Doctor, can you explain why the apex beat is hyperdynamic in MR?
Yeah, the LV is vigorously contracting. The LV is dilated and vigorously contracting. So that will lead to dynamic apex beat.
All right, thank you.
Yeah, whenever there is regurgitant lesion, which is severe, there will be hyperdynamic apex beat. Even aortic regurgitation, there will be hyperdynamic apex beat.
Doctor, if a patient is having acute ischemic MR, will it get better after re-risk or still we need urgent surgery?
See, acute ischemic MR, definitely we can attempt revascularizing the patient with the PCI, okay, if he is within the window period. Okay, so STEMIs, the best benefit will be within 24 hours. Okay, later than, after that, the benefit is not going to be there. Very, very difficult, very less likely. Okay, so we offer PCIs within 24 hours of window period. After that, the benefit will not be much.
Sir, is there a role of a mitral clip in functional MR, like in ischemic cardiomyopathy?
So ischemic cardiomyopathy, yes, that's what we were discussing about. Secondary MR, yes, there is definitely a role. The guidelines are coming up, a lot of trials are being done. Okay. So it has not reached the level of class 1. It's coming up.
Sir, these mitral clip needs anticoagulation or not?
Mitral clip per se, it's means we're yet to experience. We don't have a large volume experience. Okay. So generally, these patients will be having some problem with regards to rhythm. So there will be an anticoagulation. The guidelines, I am not yet sure. So both the severe MS patients and severe MR patients will have some amount of like rhythm abnormality. Already they will be on anticoagulation, requiring anticoagulation. Pertaining to the clip, I'm not sure.
Usually, sir, in case of where we put a foreign body, like in ASD repair, do we need
no need. 6 months of antiplatelet therapy we give, dual antiplatelet therapy. That's the maximum recommendation for any device, ASD or VSD or PDA. So any queries?
No, doctor, thank you.
Thank you. So we have a fast recall of what we have discussed before, so that we'll wind up. So first we discussed about rheumatic heart disease, mitral stenosis. Okay, we were seeing a scenario on Leydig syndrome. Correct. That is very, very rare. I don't expect in your routine clinical practice. Okay, I just wanted to expand your thinking process. That's why I have projected that scenario. Okay, so mitral stenosis is almost 99% rheumatic, especially in developing world, okay, even now. Okay, and rheumatic fever is the predisposer. Usually it occurs 2 decades after a rheumatic fever. And this mitral stenosis, clinically, how do you pick up? We'll have a tapping apex beat, right ventricular heave can be there. And how do you define severity is by the duration of the murmur. The longer the murmur is, the more severe it is. The shorter the A to OS gap is, it is more severe. Okay. And how do you treat it? If it is mild, no need to worry. Moderate, also no need to worry. If it is severe, definitely yes. If the patient is symptomatic, please go ahead for a balloon mitral valvotomy or a surgery based on his need, based on the anatomy. Okay, if it is very calcified, he might not respond well to balloon mitral replacements, with balloon mitral valvotomy. Okay. Another important thing to remember about your mitral stenosis patients is your rate control. If a patient is having atrial fibrillation, and another is your anticoagulation to maintain INR 2 to 3. Okay. Coming to mitral regurgitation, the same. If the patient is having symptomatic severe mitral regurgitation, he needs a valve repair or replacement. Okay. And medication wise, there is no great medication. We generally give AC inhibitor for avoiding abnormal cardiac remodeling. Okay. That is the only thing we give, and diuretics to avoid heart failure symptoms. Okay. And so I think you understood. Any doubts, please. I'm happy to share my knowledge. Your doubts will make me read more, go and again come back with the better answers.
Sir, if patient is having MS as well as MR together, then what will be the primary mode of treatment?
So if MS and MR together, so we discussed in mitral valvotomy initially, severe mitral stenosis with mild mitral regurgitation. Go ahead, try to do a balloon mitral valvotomy, especially if the patient is in a younger age group. Okay. See, once they cross the age of 50 years, they will have atrial fibrillation. They will anyway require anticoagulation. Okay, more than 50 years, the valve will also become calcified. Okay, so more than 50 years, you see the patient, you see the echo images, and then take a call. That is how we proceed. Okay, the valve is very much calcified, then it might not respond to valvotomy. Then we'll go recommend for a surgery. So if the patient is having moderate MR or severe MR, the only option is surgery only. Okay, there is no role of balloon mitral valvotomy, because there is risk that the patient will go for severe MR and require emergency surgery. He might die also. So it's very dangerous. Don't do balloon valvotomy if a patient is having moderate or severe mitral regurgitation with coexistent MS.
Thank you, sir.
Thank you. So any other doubts?
Can you please show the severe MS slide again?
Yeah, definitely.
Severe MS slide.
You want the echo image or?
Yeah, the points which.
Yeah, definitely.
When we'll identify severe MS.
Definitely. Yeah.
Yeah, severity. It's A2 opening snap gap and duration of
Yeah.
diastolic moment.
Correct.
So, what did you write in above in the red?
Okay, so the narrower the A to OS gap is, severe it is.
Severe it is. Okay, right. Duration of
And
the
the duration is
diastolic
longer.
moment.
Longer the murmur, severe it is.
Severe.
Yeah. Basically, the murmur
And-
occurs because of the pressure difference between the atrium and the ventricle. Okay. So there is a gradient, the pressure difference between the atrium and the ventricle, which persists throughout the diastole. So the valve, because of the increased pressure difference, the valve will open immediately after the A2. You understand? No? Immediately,
Yeah.
because of the increased pressure, the valve will open immediately. So A to OS gap narrows and the murmur will be very long.
Okay. So in the echo, when you highlighted less than 1.5 centimeter square, severe MS and GDT, what does GDT
That is the gradient.
mean?
The gradient is between
Gradient
the left
than
atrium and the left
a
ventricle.
millimeter.
Yeah.
Yeah. Okay.
It's the mean gradient. Okay, we'll get to the
Yeah.
echo.
So this is the important point in echo, which we have to like
Correct. Look
focus
at.
upon.
Correct.
Yeah.
Correct.
Okay.
So, any other queries? I hope I clarified your queries. Thank you for all you for your patient listening, and we'll meet in another class. Okay. Thanks a lot.
Okay. Thank you.
Thank you so